Good deal. Good evening, everyone, and welcome to the subject matter presentation of housing individuals who are at or below 30% of the area median income. We have tonight with us one of the task force members, the esteemed Dr. Beth Shin, as well as one of our colleagues from Metro Nashville, Judy Tackett, to talk about this topic. But before we start, I just wanted to share a couple of notes about next steps. Our next full task force presentation will be this Monday, March 1st at noon. We will be looking at the combined issues of density, zoning, and anti-displacement. I am delighted to announce that we are going to have Lucy Kempf, the Director of Planning out of Metro Nashville, as well as our very own member of the task force, Hunter Nelson, with Elmington Capital, who's going to talk about the projects, their developments, both here in Nashville as well as in Charlotte. So be sure, you should already have an invitation for that. There will be public access information for that presentation. And if for some reason you didn't receive that information, please notify me at your earliest. I'd also just like to remind folks that since this is a WebEx environment, it's a very, very live environment. And the most important thing to do in order to be able to hear each other is that we all have to turn off our mics when we're not speaking. And this includes our presenters, that when they are receiving a question from other attendees, that they also have to turn off their mics, and it will improve the sound quality, and it will improve our speakers' ability to hear folks who are asking questions. So I very much appreciate everybody being attentive to that. And of course, that means that occasionally somebody will start to speak and their mic is off. But better that way for a clear recording and a clear understanding in the environment. So without further ado, I'm going to turn this over to Edward Henley, and take it away, sir.
Awesome. Well, again, always glad to welcome our task force, those who may be watching live, staff supporting us in our work. This evening, I'm going to try to do justice, introducing both Dr. Beth Shin as well as Judith Tackett. I will be covering a little bit about their work in other areas, but of course, we're going to engage them both to present to us this evening, and then we will have time for a Q&A. So to start, I'll introduce them both, and then I will be turning over the presentation so they can present simultaneously. I'll start with Dr. Beth Shin, who we've gotten more familiar with in our time on the task force. Dr. Shin is the chair as well as professor at the Department of Human and Organizational Development at Vanderbilt, where she studies and specializes in the area of homelessness, especially in the area of prevention of homelessness and creating opportunities for aversion and averting that group from facing that social exclusion. One of the most notable studies that's been conducted, one that I've enjoyed doing a lot of research about, is the 12-site family option study, which was conducted with Apt Associates as well as conjunction with Vanderbilt. And it was an area of study that really took the time for in-depth qualitative interviews. So one of the things that I'm most excited to talk about with Beth Shin is she's not only not an academic, but she is a doer as well. So in the area of teaching, in the area of service, and then also in community engagement. Beth has served on the governance committee for Nashville's Continuum of Care, the organization mandated by the Department of Housing and Urban Development to do planning and apply HUD funds for our city. So again, she's not new in her role here, and so we look forward to hearing from her expertise. She's also served on the Healthy Nashville Leadership Council. She served at the national level as well on advisory boards for the National Alliance to End Homelessness and the National Low Income Housing Coalition. Those are all in conjunction with the board of directors for the Partnership for the Homeless in New York City. So Dr. Beth Shin, we will be asking a lot of you throughout the time here on the task force, representing an area that we know is in crisis as we talk about housing as a whole. Judith Tackett who will also be joining Dr. Beth Shin this evening in presentation to us, is the director of the Homeless Impact Division of Metro Social Services here in Nashville. In her role, she works on building cross-sector collaborations with organizations representing the government, nonprofit, and business sectors to build effective housing crisis resolution systems. I believe that we've all talked about this prior to this evening, and we understand the importance going forward of being a cross-section of all spaces, public, private, nonprofit. We'll need to continue that conversation this evening. The Homeless Impact Division serves as the backbone organization to assist partners with implementing and coordinating entry processes that prevent homelessness when possible, and then links individuals, families, and children, along with veterans and youth, as key groups for service who are experiencing homelessness with housing and services that they need. Since 2018, the Homeless Impact Division also serves as the Homeless Management Information System, that the lead for that system in Nashville, Davidson County. So, Dr. Shin, I'll be turning it over to you first, and then we will.
I think Judy goes first.
Oh, Judy goes first. Okay, excuse me. I introduced you guys in the opposite order. Apologies. Well, Judith, will you please take over for us?
Thank you so much for having me, and I'm going to share my screen. So pull up a presentation. Let me get this started with the slideshow. So thank you so much for having me, and I'm going to jump right in so we can get to Dr. Shin's presentation as quickly as possible, and then Q&A. So one of the sets in Nashville for the past few years, we have had especially one consistent data set that showed us and that we used to look at what homelessness in Nashville looks like. And that has been the point in time count. We're going to get a little bit more into the flaws or the benefits of it and the flaws of it in a second. But people who are on this point in time count is really a snapshot. It is exactly what it says. It's on January 23rd, that night, 2016 people experienced literal homelessness in Nashville. People who experience literal homelessness are considered sleeping in a shelter, on the streets, in encampments, or in other places not meant for human habitation. On the night of January 23rd, 1,432 people slept indoors, while 584 people were counted outdoors. So you can also see on this slide, I wanted to show that there was a slight reduction in literal homelessness based on this point in time count that we have seen in the last few years. The point in time count, here is an outbreak that I wanted to focus on, and you can see that about a third of the people were staying outdoors. I wanted to stress that once more, and especially because circumstances can change quickly. During COVID, by observation and by looking at some of the shelter data, fewer people are in shelters. So the assumption is, and also by observation, that outdoor homelessness has increased significantly. Point in time count also shows us a breakdown. We have done surveys in the last couple of years with people outdoors and to actually get better data. So 82% of unsheltered individuals said that a lack of income was their primary barrier for housing. They also, other reasons that they mentioned were health problems, evictions, and legal issues. 22% of unsheltered individuals and 14% of people in shelters reported that they were survivors of domestic violence. 41% of unsheltered individuals and 31% in shelters reported a problem with substance abuse. 38% of unsheltered individuals and 25% of sheltered individuals reported a mental health problem. We also are taking a careful look at the makeup and demographics. And one of the things I really wanted to point out is that 45% reported being African American, versus 28% of the Davidson County's population based on that point in time. So there is a huge disparity going on. This is actually nationwide, but it's also reflected here in Davidson County with minorities experiencing homelessness at a higher rate. Also wanted to go into 70 where people are from. That is the last residence that they stayed before the last episode of homelessness, and 74%, nearly 3/4, were from Davidson County and Middle Tennessee. In addition, we're looking at some income changes in data as much as we can. Nearly half, or about half, had some sort of income, 12 reported an earned income, and 38% received SSI, SSDI benefits. So data limitations is the point in time. I point out that we are looking at constantly improving data, and we need to do that because the point in time provides us a snapshot. It looks at the narrowest definition of homelessness that does not include many families. It doesn't include a lot of youth and young adults, because we know that especially families, a lot of families seek and live in doubled up situations, abandoned buildings, and also motels. And these populations are just not captured in the point in time. In theory, the point in time captures people in cars. In practice, it's really, really hard to do. So the point in time does not produce an annualized number, but it does provide a year-to-year comparison. So we have kind of a little bit of a baseline, and we also in the last few years have improved the data and complemented it with surveys. It's self-reported, but it gives us a little bit more nuance to the to the data. In contrast, I just wanted to let you know we do not yet have an annualized number of homelessness in Nashville, but we know that alone at the Nashville Rescue Mission, about 7,000 to 8,000 people per year are reported to go and stay there. And that's an unduplicated annualized number. Also, we know the public school number. That definition is wider. That includes the families, that includes people in doubled up situation and children in motels, and that school years numbers are usually 3,000, 3,400. Those are the reports that we are aware of and we're getting from that data set. So one of the things I really wanted to go into, the Homeless Impact Division took on a community database called Homeless Management Information System. We've really managed it and administered it on behalf of the community for about the last couple of years. The goal is to look at the homelessness landscape and get a fuller picture at any time. So federal government requires communities that apply for certain federal grants to have an HMIS. It allows us to look at different populations and the demographics of those different populations. I've listed them here. And it also allows us this systems performance measures. And that is kind of key to knowing how we're doing as a system, where we have gaps, where we need to improve, where we need to invest. The system performance measures, some of them include length of time homeless, return to homelessness, the number of people who experience homelessness, employment and income growth, the number of people who become homeless for the first time, and successful housing placement and retention. So here's an example of what we can do when we have actually a lot of providers participating. HMIS data, as you know, any data set is only as good as the data that's being entered. So we have taken and grown partners that enter the data, and actually since last year, just a few months, we have the system built where it's safe to share data, where providers have agreed to share data, which makes it actually functional for our community. For the first 15 years that HMIS was required in our community, it was a closed system. That means providers entered data, but it didn't share data. It was not, this way we were not able to produce unduplicated numbers. Now we have changed that. but because of this legacy from the past years, we just don't have a lot of providers or everybody yet entering all the data. So we are working on that. It's improving. We've increased that tremendously. But here is an example when we look at veterans. We have worked very hard with the veteran providers, and we are pretty confident that this data is accurate as it can be right now. Veterans are identified as quickly as possible. And I'm talking again, veterans experiencing literal homelessness. So this example really looks at what we call a by name list. We know veterans by name. There are meetings where providers can come together, look at the most vulnerable veteran, and discuss how to assist that person. So it's really individualized, really focused. So in January, 171 veterans were identified in our community as experiencing literal homelessness. We also look every month on the inflow. Inflow means people coming into homelessness. It could be somebody who has previously been homeless, is newly homeless. It could also be somebody, a veteran, who has been in HMIS and for 3 months was not found, and we kind of park that person and don't count them as active in our by name list. But if they come back, then they're back in the inflow. Outflow, obviously that's a housing destination, is the preferred outflow. It also can be inactive. That means somebody just disappeared or hasn't been a provider hasn't been able to touch base with this veteran. But there are attempts made to continuously work with the veterans on that by name list. So what we want in this data set is really more outflow with housing destination than inflow. So this way we know, is veteran homelessness going up or down, or are we about the same? And that's kind of data-driven approach that we want to really focus on, where interventions need to happen and what we need. So when we talk about intervention and what needs to be done around homelessness, of course, we're talking about housing people and assisting people with housing and supports. We are currently in a housing search effort. Here's how this came about. So during the COVID crisis, we have received additional federal dollars in a grant called Emergency Solutions Grant. That we always receive some federal dollars for emergency solution grants. The 2020 allocation was $450,000. I've seen it go up to $600,000 in previous years, but that's about the regular allocation that we get per year. And and I just wanted to put that in perspective. All of a sudden we get $10 million. So what are we going to do with that? So these dollars come from the Federal Housing and Urban Development Department to MDHA, and then together with us, and we also receive technical assistance, a consultant from the Housing and Urban Development Department with that, and together with the community providers, we sought a lot of input on how do we spend these dollars. Then they are granted out to nonprofits. And the nonprofits, the community decided a lot of these dollars, we need to really focus on housing. I mean, housing and homelessness. Homelessness is a housing status. And if we want to have solutions to homelessness, then the housing conversation just must be a piece of that. So the goal is to house 400 people by the end of this year. And how are we doing that? I'm highlighting here, there are more nuances to the grants that were given out, but there is quite a bit of focus on a collaborative street outreach effort to identify people quickly, to use HMIS. And that's one thing I wanted to mention too, that it's a federal requirement that all the data is entered into HMIS. So we will have rich data around this effort. And then the majority is going into programs for nonprofits that do rapid rehousing. Rapid rehousing provides under this grant dollars up to 1 year in rent subsidy for people, plus wraparound case management services. Sustainability is a concern for this population, as you know. And we're working right now closely with MDHA and the community to look at the different types of housing vouchers, including Section 8. I believe you had a presentation on that. VASH vouchers, that's Veteran Affairs Supportive Housing vouchers, and Shelter Plus Care, another voucher type that's very similar to Section 8, but comes with some services. So the goal, some of the people that will receive these COVID dollars, these rapid rehousing dollars and assistance, it limited rapid rehousing in this instance, it's for 1 year. So we know that some people will not be able to pay for their rent fully after 1 year. And even with the case management that is focused on income increase, so that's kind of why we need that conversation around ongoing subsidies and how we link people to ongoing subsidies. The rent assistance under rapid rehousing is following the fair market rent limit. So for an efficiency, that's $998. One of the things that we have also launched is a coordinated landlord engagement effort. We meet with community providers that do landlord engagement and outreach to landlords every 2 weeks to coordinate that effort, see how we can use databases on that. And then one of the things that has helped us in the community is motels are not doing really well right now. And motels can be utilized as efficiency housing as long as they have, I mean, the units need to have their own bathroom access, or a person needs to have access to their own bathroom. There needs to be a fridge and a microwave. And the landlord, if it's a former motel owner or if a motel is used now as housing for that, has to agree to enter a regular 1-year lease with the tenant. Results since October, when the first rapid rehousing programs were started at the nonprofits. I want to point out on this one, these are cumulative results. So to date, as of Monday, 253 people have obtained housing through this rapid rehousing search with these COVID dollars. So that is huge for our community. And I also wanted to add the collaboration effort around this has been tremendous. It just really shows when there is available, when there are available resources, how much the collaboration, the coordination, and all this work, how quickly it can increase and be focused. One of the details for these results, this is all coming out of HMIS because everybody is entering their data in there. So 357 people are being served in the rapid rehousing programs. That means they're enrolled. The programs are actively working with them to look for housing, to remove housing barriers with them and help them obtain housing. Of those 356, as I mentioned before, 253 have moved into those permanent housing settings. They have a 1-year lease. And there is some breakdown for you to look at, you know, how many households with children, without children. And a lot of the focus that we have seen in this housing effort is on individuals and on people that are living outdoors. And another data set that we monitor is the average length of time from enrollment to housing. And it's 26 right now. And then also the length of time people have spent experiencing homelessness prior to the housing placement. And I just want to point out, when you look at the last number there, 108 people have spent more than 2 years being homeless. We need to look at, when we talk housing, we need to look at those subsidies, those rent assistance, and the support services and wraparound services that go with it. One of the things I know that your task force is looking at is about access to housing. And I wanted to, the Homeless Impact Division is actually also managing what is called the coordinated entry process. This is a process we use to identify, prioritize, and connect people with the appropriate housing and support services as quickly as possible. And when I say we, it's really, I use that a lot as we in the community, we work with the providers on that. We have a lot of meetings to coordinate, and we have a lot of trainings that my team is doing with the providers to understand in nuances how all of this works. So to highlight some of this, coordinated entry is a process in which the entire community participates, and it really looks at the access, assessment, prioritization, and referral of people to housing. And the goal is, again, to speed up that whole process from homelessness to housing. At this point, I just want to point out, when we talk about ending homelessness, we're talking about the length of time that people experience homelessness. We cannot prevent the loss of housing. A lot of times that's out of our power, but we certainly can build a system that leads people to housing quicker. And that's kind of the systems approach that we are taking. We are moving, we are not, it's really moving away from the first come, first serve base approach. And right now we are using in the coordinated entry system or coordinated entry process a prioritization called a VI-SPDET, a Vulnerability Index Service Prioritization Decision Assistance Tool. It is used widely among other communities. This is, but we are, as other communities are, looking at how we can actually nuance our assessment process, what assessment tools are maybe even more equitable, and really investigating that and looking at what we need to look and invest in the future. Because these are COVID dollars and because we're in a pandemic, we have added prioritization points for unsheltered homelessness, people that are elderly and also have pre-existing health conditions. That is the purpose why we got these $10 million to address COVID. And so we added that into the prioritization. And then, of course, length of time people experiencing homelessness is part of that prioritization as well. Coordinated entry is also a referral tool. Here is a list of some of the resources that through coordinated entry. We really are interested in adding more and more, especially housing units. The rapid rehousing through the emergency solution grant COVID dollars right now is one of the biggest programs right now that we are referring to, and we just need more of these built-in referrals, and we're encouraging landlords to work with us on that so we can refer through the coordinated entry based on prioritization. But that also means that we need to lower barriers to housing so that people can access units. And then I want to finish with one final data point. This is the reality. The life expectancy of people experiencing homelessness is 10 to 15 years shorter than that of the general population. And here are the sad numbers for Davidson County. 146 people in Davidson County. These are our neighbors that died as a consequence, not necessarily as a consequence of homelessness, but they died without housing. And I think that's just something that we need to keep in mind, all of us. Housing saves lives. Housing is healthcare. Housing is a foundation for people to succeed. And so I would like to turn it over to our national expert, to Dr. Beth Shin. I'm going to stop sharing this screen, and so the presentation can go over. And thank you for having me.
Thanks. Thanks so much, Judith. And it looks like I can share now. And okay. So thank you so much for allowing me to present tonight and to try to urge you not to forget our poorest neighbors. So, sorry, I need to, here we go. So you know this already, but let me remind you. Area median income in Davidson County is a tad over $60,000 a year. 60% of that's about $36,000, 30% is about $18,000 per year. But a full-time year-round minimum wage worker, 40 hours a week, 52 weeks a year, takes home only about $15,000 or 25% of area median. An individual with social SSI disability benefits gets only just over $9,000 a year. Tennessee is one of the few states that doesn't supplement federal SSI grants. The average TANF welfare grant is just under $3,000 a year. And when you add the wages that the average TANF family makes, we get up to about $13,500 a year. So well below 30% of area median. As Greg Claxton told us, and I just stole his slide here, the biggest deficits in affordable housing are for folks below 30% of area median. So what do people with those low incomes do? Well, they pay well over 30% of their income on rent. They pay 50%, 60% or more on rent. They double up with other households in the same dwelling unit because they can't afford a place of their own. When those two arrangements break down, they become literally homeless. And as Judy told us, they die prematurely. Here's what doubling up looks like in Davidson County. This is an estimate prepared by my student, Molly Richard, from the American Community Survey that says that over the last 5 years, just shy of 8,000 people on average were doubled up at any point in time in Davidson County. So now let me switch to national numbers, since Judy's told you a lot about the local ones. So over 500,000 people are staying in shelters or transitional housing programs or found on the street on a single night in January, the point in time count that Judy told us about. And we know we miss people. HUD counts those two groups because their focus is on getting the services, housing services, to the people who are at highest risk, who need them most. Over the course of a year, over 1.4 million people use shelters. That doesn't count the people who are out of doors. And the Department of Education, that uses a broader definition of homelessness because their focus is on trying to get educational services to children, uses this broader definition, as Judy told you, and they report that about 1.5 million school-aged children are homeless over the course of the year. And again, we think people are missed because families don't necessarily volunteer to their schools that they've experienced homelessness. But it turns out that the ways to get the highest number of people experiencing homelessness is with telephone surveys. So back in 1990, early in the current epidemic of homelessness, a telephone survey of people living in regular housing, no homeless shelters or barracks or jails, found that 7% of adults said that they had been literally homeless at some point in their lives, and twice that many if we count doubling up. So most homelessness is temporary. It's a temporary state that people pass through. And that gives us a lot of points of intervention. How do we prevent homelessness? How do we help people escape it? How do we stop generating more? A few more facts. By HUD's reckoning, on a single night, there are roughly equal numbers of individuals without children who are sheltered, individuals who are on shelter on the streets, and families, most of whom, thankfully, are sheltered. Infancy is the age at which an American is most likely to stay in a homeless shelter. Shocking, isn't it? Children are a blessing, but they require food and special furnishings, and they outgrow their clothes every time you turn around. Most importantly, they require a parent either to pay for costly care or to stay home to provide that care. Rates of shelter use stay high in the preschool years, They drop when children reach school age and childcare expenses drop. And homelessness rises again in young adulthood when some of those young adults are parents of some of those babies. So when we think about the face of homelessness in the United States, we should think not just about the guy on the left, but about the child on the right. There's one more thing that's important to know about people who become homeless. As Judith told us in Nashville and nationally, people who face racism and other forms of social exclusion are particularly vulnerable. So African Americans and Native Americans have disproportionately high rates of homelessness, even among people who are poor. If I had more time, I'd explain why 4 types of discrimination are key in incomes, wealth, housing, and incarceration. People with disabilities face the same kinds of social exclusion, and among youth, LGBTQ youth are more likely to become homeless than heterosexual youth because of exclusion by their parents largely. But even among people with disabilities and among LGBTQ youth, African Americans and Native Americans are at higher risk. We have 3 powerful pieces of evidence about what caused the current epidemic of homelessness, and that it's basically a housing affordability crisis. What I mean by the current epidemic is the evidence is the homelessness that began in the early 1980s and continues today. One piece of evidence comes from history, what was going on when that current epidemic of homelessness started. Another piece of evidence is from geography, where rates are highest. And a third piece of evidence is from what we know prevents and ends homelessness. In 1970, there was a small surplus in the number of housing units that people at the bottom of the income distribution could afford. And we had very little homelessness. But over time, income inequality increased, rents grew, and incomes did not keep up. That surplus turned into a larger and larger deficit, and homelessness arose, first among younger men, racial minorities, women, and then families. This figure illustrates the relationship between housing costs and rates of literal homelessness. It shows the 25 largest metro areas in the United States. The left axis is the rate of homelessness, the point in time count, divided by the total population. The bottom axis is median rents, and you can see a clear relationship here. Homelessness is higher in places with particularly high rents. Those metro areas tend to be affluent, but they also have high rates of income inequality, and therefore many people who can't afford the high rents. And here's the final piece of evidence that homelessness is fundamentally a housing affordability crisis. A rigorous experimental study showed that providing housing vouchers that hold housing costs to 30% of income to poor families who are receiving welfare wiped out the risk of homelessness. The 12-site family option study that Edward mentioned earlier provides additional strong evidence for the benefits of access to long-term housing subsidies. Offering families housing vouchers that reduced rental costs to 30% of their income not only reduced every measure of homelessness and residential instability, but it also had radiating impacts. It reduced separations of children from their parents, children's school moves, absenteeism, and behavior problems. It reduced food insecurity. For adults, it reduced domestic violence, psychological distress, and substance abuse. That is, vouchers reduced some of the individual problems that can sometimes lead to homelessness, and it provided a platform for families to solve other problems on their own, even without any additional services. As one mom put it, for me to actually have a nice house for our children without having to be completely worried about rent for the month, because my husband is trying to go back to school full time and so am I. We know we're supported and we don't have to worry about losing the house because we're trying to go to school and work and we're safe, we're okay. We'll get things back on track. Further, few families were ineligible for the vouchers, lease-up rates were high, and all these benefits cost only about 9% of usual care in the communities we studied. And Black families were just as successful as white families in using and retaining the vouchers. The success of housing vouchers in ending homelessness provides support for the theory that homelessness is, at its core, a housing affordability problem. A second intervention we tested in the study was short-term rapid rehousing subsidies, lasting in our study an average of about 8 months. Judy says that we're now going with about 12 months in Nashville. If there was an effect of the rapid rehousing subsidies on housing stability, we missed it by the time we first came back for a follow-up 20 months after people entered the study. There were scattered effects on other outcomes, but pretty much consistent with chance. The main selling point for rapid rehousing is cost. It's no worse than usual care, and it's cheaper. So on that ground, it should be preferred. But it doesn't do much to end homelessness. So I'm really worried about the long-term housing instability of the folks that we're getting into housing now. The last intervention in our study was transitional housing, where families live in supervised settings and receive extensive psychosocial services. But though the programs are designed to serve families experiencing homelessness, they screened out far more families than did the public housing authorities that administer housing vouchers, and take-up by families was low. Families could stay up to 24 months. So transitional housing had small effects on use of homeless shelters during the period that families were in those transitional housing programs. But the offer of transitional housing did not affect doubling up. The theory behind transitional housing is that families need to address the problems that brought them to homelessness, or that are the consequences of the homeless experience, with psychosocial services before they can flourish independently. This approach is sometimes called services first, in contrast to housing first. The family options study provides no evidence for this theory. There were no benefits of transitional housing for psychosocial outcomes, child welfare, or self-sufficiency, and the programs cost slightly more than usual care. Transitional housing may be of use to some groups that are really transitioning, such as youth aging out of foster care, but we didn't study those groups, and we found no evidence of benefits for families. Vouchers alone end homelessness for most families. People with disabilities often need more help. Supportive housing, that is subsidized housing with services under people's control, ends homelessness for people with serious mental illness and substance abuse problems. The traditional approach here is sometimes called the staircase model, in which people earn their way to more independent housing by addressing their behavioral health challenges. Like transitional housing that didn't do much for families, this traditional approach can be called services first. Housing first, in particular a model called pathways to housing, bypasses the steps in the staircase model and gives consumers immediate access to independent permanent housing without preconditions and with the services they choose. There's strong experimental evidence that this approach works better than the old staircase model. Here's the evidence from a program from an experiment that I worked on in New York. Participants had lifetime histories of homelessness of an average of 6.5 years, and they averaged 4.9 prior psychiatric hospitalizations. This graph shows the housing trajectories that people followed, specifically the percentage of time they spent homeless in each of the first 12 months of the study. Months are along the bottom there. The Pathways to Housing program had the goal of getting people into ordinary housing. The control programs had the goal of getting them into appropriate housing programs, but both had the goal of ending literal homelessness. And so we looked at literal homelessness, and we looked at the patterns of these trajectories. There was a quick group that got into housing or housing programs in the first few weeks and stayed there. A median group took a little longer, but got off the streets between months 2 and 5. A slow group took longer to get indoors and didn't necessarily stay there. An in and out group got off the streets, but then they became homeless again. And a never group basically never came indoors. There was also an outlier group, a group I can't graph because they had multiple ins and outs, but the ins and outs don't line up with each other. So, sorry. These trajectories differed enormously by the experimental treatment. 3/4 of the Pathways group got into housing within the first couple of weeks, and they stayed there. That was also true of 43% of the control group. All forms of supportive housing work for many people, but some aren't willing to put up with the restrictions of the Services First programs. Over 90% of the people assigned to pathways got into normal housing within the first 5 months in the quick or medium groups, whereas 22% of the control group essentially never made it into housing, and another quarter came in slowly or got in and left again. So we know how to end homelessness if we devote the resources. The US has cut veteran homelessness nearly in half with the combined efforts of the Veterans Administration, the Department of Housing and Urban Development, and state and local governments. Veterans were targeted with special supportive housing vouchers, following the Housing First approach, and with other rental subsidies. VA screened veterans who came in for medical services for risk for homelessness, and cities put veterans at the head of their lists for housing. The US also reduced chronic homelessness by increasing the supply and targeting of permanent supportive housing. When we put our minds to it and we add resources, it makes a difference. Families and non-vets have not been a priority for these coordinated national efforts. So what does all this mean for Davidson County? We should continue to build housing affordable to people with incomes below 60% of area median. And poorer households will move into it, paying way too much for their rent. I would recommend that MDHA reserve housing choice vouchers for families or for households, singles or families, below 25% of area median. You all have pointed out that you just can't build affordable housing for folks with incomes that low. So we should use the one resource that we have and concentrate it on folks who are the poorest. Because many people who get vouchers don't succeed in using them, we need to provide additional incentives to landlords to take people who use those vouchers. Judy talked about temporary rapid rehousing subsidies available from HUD, especially now with stimulus dollars. I'm skeptical there'll be enough for many households, but they give people time to get on waiting lists for vouchers. We should think of them as a bridge. Many of you have worked with Friendship House to provide affordable housing for people with developmental disabilities, using every source of funding available. And we need to do more of that for people who need only a little help. We should lobby the state to use its TANF surplus to get families into housing. The first statutory purpose of TANF is for children to live in their own homes, so kids should not be homeless. We need more supportive housing of the sort that Metro is building, and it will require ongoing subsidies for services. But you tell me, I'm just a researcher. You folks are actually developers with a lot of experience. So I urge you, I challenge you not to forget our poorest neighbors. We can also work on prevention. We have strong evidence that a few prevention programs work. As I noted earlier, there's experimental evidence that the same housing vouchers that end homelessness also prevent it for poor families. New York City has a program called Home Base that's essentially good old-fashioned social work backed up with some cash resources. There's evidence that it helps some individuals and families avoid homelessness. The last program with strong evidence of success is cash help for eviction prevention. Most people who are threatened with eviction do not go on to become literally homeless. In one rigorous Chicago study, it was about 2% over the next 6 months, but cash help reduced the percentage much further. All of these programs had the biggest effects for people who are worst off. We have a tendency to focus prevention efforts on people that appear worthy. We will have a lot more impact if we instead give services to people who need them the most. There are other prevention services that may be promising, but we have less evidence at this point. In addition to helping people on the brink of homelessness, we need to change the broader societal conditions that are the causes of homelessness. I showed earlier that most homelessness is temporary, so we're never going to put an end to homelessness unless we stop generating it. And we have pretty good ideas about how to do that. Because housing affordability depends on the gap between housing costs and incomes, anything that reduces housing costs or raises incomes at the bottom of the distribution will help. We also need to combat social exclusion with a plan for affirmatively furthering fair housing. So the evidence is incomplete, but we know how to end homelessness. We know what causes it. We know how to help people leave it. We know a lot about how to prevent it. What it takes is political will. Homelessness, I would argue, is a choice, not by people living on the street, but by the rest of us when we turn the other way. And I review the evidence behind everything that I've said here in a recent book about homelessness and what to do about it. I call it In the Midst of Plenty, because I argue that society has the resources if we choose to devote them. So let me stop there, and I'm sure Judith and I would be happy to try to answer questions.
Absolutely. Well, first, I'll thank both Beth and Judith for their presentations. Extremely in depth as it relates to metrics and information. And I do love the complement between the local, looking at the national, and then bringing it back to a local level. As someone who also is a big advocate of the calls to action, Beth, I think that was great. I mean, there's so many great examples, and there's a lot of data and information that shows that there is tangible things that have been done, gathered over your times researching and working with others in this field that show we do have resources, we have strategies and tactics, and we have programs that work, some more effective than others. And so we have a lot of things we can build off of, a lot of lessons learned. I will say that I want to go ahead and get to a few questions that I see, and I see 2 hands up already. I'll apologize, I don't know whose hand was up first. So Southern gentleman style, Kay, I'm going to go to you first, and then I'll go to John. John, please be patient.
Thanks, Ed. You're a real gentleman. My first couple of questions are for Judith. Judith, do you have the participation rate of social service agencies in the HMIS system? I know that's been something you've been working on the last few years. That's the first question for you. And then the second question for you, I know there's been considerable outreach during the pandemic to homeless camps around the county. And do you have an estimate of the count in terms of estimated number of people you're finding in those camps? And then my last question is either for Judith or Beth. I'm trying to be quick. Best practice, evidence-based models for moving people from homelessness to permanent housing and keeping them there towards stability. Thanks.
Thank you so much, Kay. So we have increased the participation rate in HMIS. It is not even close to where we need to be, especially since, so HMIS, since it's a federal requirement, traditionally organizations that received federal grants have contributed their programs that have federal grants, but they're not inputting all the data of all their programs. So we have seen some of the larger organizations really working hard this last year to change that. We have we had about 30, just under 30 organizations participating. We are now closer to 40, and that's all within the last few months. So we see an increase, but we are not where we need to be. We have a very low shelter bed participation still, but we are working actively with Nashville Rescue Mission right now on getting release of information. Nashville Rescue Mission is on board to allow us to get data into HMIS that will be critical for us to have a fuller picture. So that's your first question. The second question on encampments. The point in time we had outdoor counts there, as you saw. This year we got a waiver due to COVID. Our community elected not to have an outdoor count this year. I have actually, right now we're starting a push and asking the Homelessness Planning Council at the next meeting to support that push to encourage outreach organizations to enter into HMIS and pull a first report in HMIS for outdoor homelessness by the end of April. So we're really engaging in that push. And it's not just a one push and do it once, it's coordinate with us, come together. Homeless Impact Division will have meetings with the outreach groups to set up a process to do this on an ongoing basis so that we have this information anytime. So that's what we're working on right now. And Beth, do you want to take the best practice on a?
Sure. So I think the best practice is this kind of housing first model where you offer people real housing, not a housing program, and you give them wraparound services, but you don't put a lot of requirements on them to get into housing. You know, it's hard enough to kick a substance problem when you're housed, and it's impossible when you don't know where you're going to sleep tonight or you don't know where your next meal is coming from. So you get people into housing first, and then you provide the housing, the wraparound services, but people choose the services that they want. And what we're finding in Nashville as elsewhere is that when people are actually getting into housing, then folks line up to do that. So, you know, you may have broken bread with people at Room in the Inn and they said, yeah, I'm not interested in housing. And people who outreach workers have heard this, but when somebody else in that encampment actually gets into housing, all these people that said, nah, I'm not really interested in housing, boy, they're lining up for it because it depends on what's on offer. If what's on offer is housing, people want to come indoors.
And I want to add one thing in Nashville, when we talk about housing first, nobody has really done this really well. We don't have the right supports. We have too many barriers and conditions before people get into housing. And there is, even amongst service providers, a struggle to understand what this means. So I'm using a lot of times the term housing crisis resolution system to really look at these systems. It's something that people can understand where they fit in with their programs. And it's really adjusting. The end effect is the same. All programs should be adjusted to what we're doing. Let's do it well. Let's do it in a prioritized way and with a housing focused approach. It's that housing first approach. It's like, even if somebody wants to have a little middle step there or is not, you know, that getting people to housing as quickly as possible must be our goal with the right subsidies to sustain it and the supports.
Thank you, Judith. And it really comes back to, again, like so many other things, is really a good housing system. And in this case, it's a model that fits moving people out of homelessness and into a place of stability. And all that is a systems-based approach. Those are my takeaways. Thank you.
For those great questions, Kay. John, would you go ahead, sir?
Thank you. So, it just makes sense. And you've studied, you don't have to question the answer. What practically do we do to get these folks housed? I mean, do we issue them vouchers that allow them to go to the market and choose a place and we'll cover the difference wherever they choose? Do you put any limitations on that? It doesn't seem like Section 8 is getting us to the promise because we're limited in the number of Section 8 vouchers. We have 10,000 people waiting in line for them, and we got landlords not willing to embrace Section 8. So get practical with me for a minute. Get concrete. We're bought in. We're ready to go. We got all the money we need because we're a rich city. What do we do exactly to solve this? Because we're committed to getting homelessness gone in Nashville.
You want to take this, Judy, or?
You start, I'm still taking notes like crazy, like, yeah, so.
We need to do what we're doing, right? We need to, but we need to do more of it. So we need more housing choice vouchers that are dedicated to this. You know, there are cities like Vancouver and Oregon where the housing authority has simply turned over its entire waiting list to the equivalent of Judy's operation, so that folks experiencing homelessness are the folks getting into public housing at that point. And, there are two models of doing it. One is the scatter site model, where you use housing choice vouchers and you pair that with services. You need the money for services. Housing First is not housing only. It's not just, give somebody a voucher and run away. That works for families, but it doesn't work for folks with more serious problems. And the other model is a congregate model, like the building that we're putting up downtown, that is going to be supportive housing for some people, not enough. And then there are creative solutions like Friendship House that use the kinds of subsidies that you folks are so great at cobbling together to provide inexpensive housing. And instead of extensive psychosocial services, they have students or other people come in to be friends with the folks with developmental disabilities who need a little help but don't need extensive services. So basically, we just need the resources and we need to deploy them.
Let me ask a follow-up about the housing choice voucher. Describe what that is, how it might work, and just if it is, contrast it to a Section 8 voucher.
It's just a Section 8 voucher. It's HUD's preferred term for a Section 8 voucher, for not for project-based Section 8, but for individually based Section 8. So it's individually based Section 8, and you probably need some help with landlords, getting them to take that. In the Pathways to Housing model, one of the services that's provided is not to the individuals, that are services to the individuals, but to the landlords, so the landlord knows if there's a problem, there's somebody to call. They will do things, if the person hears voices and goes crawling into the wall to try to find out where they're coming from, they'll come in and plaster and paint before the landlord finds out about it. So that trying to make people good tenants with their landlords is an important aspect of the scatter site kind of model of Housing First.
And to follow that up, that's exactly, we need to start with where the housing is. So let's also really look at that landlord perspective. Landlords are looking for tenants that they just want their rents and kind of a quiet tenant. So the supports that we are providing and need to look at is, what are the local subsidies that we have? So if it's Section 8 voucher, is that even enough for a landlord for it to be financially attractive in a market where there is so much competition? And then the other thing I wanted to, and then also case management and support services, and what I cannot stress it enough, how much it means to landlords that there's somebody, that they don't become the social worker. And then access to housing. I talked a little bit about coordinated entry and prioritizing the housing and the intervention based on the needs. For that, we also need that data-driven approach to really understand who is out there. We have something called a by name list, where we know people by name and really look at the most vulnerable people. If one organization doesn't know how to overcome some of the housing barriers, others step in, and that's where some of the coordination needs to happen. So I can second, we have bits and pieces in place, but we just do not have the full system in place. And we need to understand in our community that a system is really building relationships, lasting relationships between the different providers to work together. We can have the best programs. A system is not the sum of all programs. It is really looking at identifying, having these performance measures in front of us, and then investing. And maybe we need an additional local subsidy on top of supplementing Section 8 or something as an incentive for landlords, that these Section 8 vouchers become attractive again for them.
Thank you.
So Dr. Coleman, I saw your hand, but I see it's down now. So if you do raise your hand again, I'll be happy to recognize you. But in the meantime, Emily, I see your hands up. You want to go?
Yeah, so two things. One is just a comment where, I certainly see and appreciate the value of prioritizing housing choice vouchers for people who are homeless. And we need to recognize that by function of doing that, it means that we will have fewer vouchers going out the door because they cost more on an ongoing basis, right? And then we are leaving a lot of people because Nashville's approach with vouchers in large part has been anyone who is eligible, can apply, right? And so if we take away that approach and really say, hey, let's strategically target this resource, it makes the most sense, this is the population that needs it most, we will have fewer vouchers on the street, and we're going to have this additional need. And so I think part of our conversation has to be, so what do we do about people who do have higher incomes? And how do we get that to be separated from the need from ongoing subsidy and whatever affordable housing solutions we're bringing to the table? So that's just a comment. My question, because frankly, I just don't get it and I'm not close enough to this, Judy and Beth, why has there been so much resistance to embracing permanently supportive housing? Even from, I understand that this continues to come up in CSC. My understanding is that we have not been competitive for federal programs because our approach is basically not empirically sound in the city. And on top of that, we just had all of this ESG money come in, and I'm not clear on why we're making the decisions we are. And I would just love to have some candid light shed on that.
Yeah, I'm going to start with that one. So to start with ESG dollars, we need to be very clear. They cannot fund permanent supportive housing. They can do rapid rehousing. So we're limited there on that one. It's because it's time limited. Permanent supportive housing, I wouldn't say people are resistant to it. I think it's more of the resources aren't there to provide the supports. So MDHA has shelter plus care vouchers. They really are permanent supportive housing, but we're not implementing them. Let's just be honest. We're not implementing them to the best utilization of that permanent supportive housing. Yes, they're vouchers that have the permanency in the housing when somebody has them, but the supports are just lacking. It's where is that the resource to bring the right level of supports. And that's also in conversations with providers that I sense a whole lot. It's this, they want to do permanent supportive housing, but it's this fear of who's then, where there's the resource. It's like, okay, we cannot serve, let's say 100 people forever or 20 years, and then we don't have any money to serve anybody else. It's kind of that type of, where is that permanency in the support services? I think that's where a big lack is. And we are not a Medicaid expanded state. So some of the state policies play into that too. But I also believe there are other states that we can look to that are also not Medicaid expanded states, and they have found some innovative solutions and looking at state level support on that as well. And we can do more of that.
I think there is also a resistance to giving services to people that we don't think are worthy. We want to give our services to the worthy poor. And if people are still using substances or aren't dealing with their behavioral challenges, some providers are not really interested in taking them on. And the evidence is that you don't enable substance use, you don't increase substance use if you bring people indoors without requiring them to be clean and sober first. You give them a platform where they can deal with their problems, though they need supports to do that. They need help. But services work a lot better when they're voluntarily chosen, as opposed to when they're foisted on people. So I think there is a sort of ideological thing that's going on as well that makes it hard for people to get on board. A final thing I'd say is that in some ways, the housing first model works better in scatter site housing than it does in programs. So if I'm using, and you're in my next door neighbor and you're trying really hard to be clean and sober, and here I'm using, that can be a really difficult situation. But if I have a private landlord, because I have a housing choice voucher, if I make a ruckus, I'll get thrown out just as you or I would get thrown out. But if I'm using quietly behind closed doors and putting my bottles neatly in the garbage, nobody's, it doesn't create the same problems for my neighbors. And so in some ways, the kind of housing first rather than the services first approach works particularly well with scatter site housing, but the services have to be there.
Making sure I'm not missing anyone. While I wait to see if there's another hand. Oh, I see Dr. Coleman. Sorry, your hand's back up. I want to make sure I get you this time. You have to unmute Dr. Coleman.
My other question was answered. This is to both. We don't practice the housing first model here in Nashville. What kinds of steps could we take to move toward that? And the second one is your point about scattered site for supportive services is really, really important, because so many of us who are housing advocates have really worked hard to make sure we are always mindful of not concentrating poverty or concentrating challenges that some of the people in this group may have.
Yeah, and I think that is really important, not concentrating poverty and not concentrating people with heavy duty social service needs. And when I said that, MDHA should set priorities for their individual Section 8 vouchers for folks below 25% of area median, I didn't say that for public housing, right? Public housing is necessarily a concentrated place, and MDHA is doing great work in trying to get that to be mixed income housing, but you may want to go higher up on the income ladder there. In the scatter site model, I think you can focus on the people with the greatest needs. And I don't think I answered, I've forgotten your other question, Dr. Coleman.
Since we're not implementing housing first in Nashville, what steps do we need to take to move toward that model, and what are the barriers, if any? Well, obviously there's some.
Well, one thing we're doing now is that the Homeless Planning Council, in its prioritization of grants so HUD gives grants directly to the housing and service organizations, and the Homeless Planning Council gives HUD a priority list. And we give points on that priority scale for programs that really embrace housing first. So that's one thing that we're doing. But we need the resources and we need the buy-in. I don't know, Judy, if you can say more than that about what we can do.
Yeah, and I agree. So I would say the answer there is dedicated funding source for support services that are ongoing, and really looking at that. Because even we're trying to prioritize housing first, but we just need to be super honest with ourselves. Even when we prioritize programs that house people quickly, but they're not truly housing first because we do not really monitor and the level of supports that are needed. And so a dedicated funding source for support services, and really looking at that and digging deeper there.
I agree with that. Housing first is not housing only. It's not just giving people a housing choice voucher and closing the door. It really has to involve those services, even if those services are under people's control.
Judy, do you have any estimates of what those services, what are we talking about budget-wise? I mean, if you have something more that you could share with this group, just so that we have any understanding financially of what we're talking about, that would be really helpful.
Yes, and one of the where I'm always reluctant is I do not yet have even the overall population that I'm comfortable with, that HMIS data, but and the next thing is on top of my head. I looked at permanent supportive housing for some of the most vulnerable people. And when you take a case management load of 1 to 20, 1 to 25 to have the intensity of services with a case manager there, then that would be an additional annual cost per person. I would, if I'm correctly, it's also late for me, but I would be $6,000, $5,000, $6,000 per person per year. But then we also need to calculate in that there may be some people that then choose to go and have, people go into housing, they may have a substance use issue, and then they're starting, when you take a harm reduction approach, they may be starting to realize, you know what, it's time for me to really look at that substance use. And then there may be some additional costs on top of that case management to get somebody into the type of program that then to get sober, that they need to go in. So the cost I just said is really for the ongoing case support and management, and have somebody there, but it could go up and down based on need.
We won't hold you to it, but that's helpful in and of itself, just to have any idea. Thank you.
Kay, I saw your hand go up if you had a question. You're muted, Kay. Kay, you're muted. Sorry, before you get too far.
Thank you. Thank you. Looking at other cities' affordable housing plans and longer term plans, Denver's current plan has a particular focus and emphasis on trying to end homelessness and get people into permanent supportive housing. And they actually have a budget for what that would, projected budget for that. And then they've also tried to align identification of dedicated funding sources to fund those supportive services. So I'm just saying, Beth and Judy, there's a model that I discovered just studying other cities' plans.
Yeah, the Canadians probably have the best cost data from what's called the At-Home Chez Soi study, which is a 5-city study that shows that Housing First works better than traditional services to end homelessness. And there are some offsetting costs for things like arrests or the health costs are a mix. You get people using fewer emergency room services, but more other appropriate services. And so you don't actually save a lot of money on health. There's some offsetting costs that they've done the best cost analysis. I'm not sure it translates perfectly to the US context, in part because they have better health coverage in Canada than we do, especially in Tennessee.
And one of the costs I also wanted to bring up is like street outreach services. We cannot overlook how important that is to build that relationship with people, especially when they experience long-term homelessness, just to build that trust, to actually really look at early on what the barriers to housing are, and do those initial assessments and really work with people there. When people are severe mental health issues and are on the streets, there are some very intense street outreach models that they are going to be costly because it includes psychiatric nurses and really but that's a good approach to really look at some of the most vulnerable people. I want to share one example that was a huge success for Nashville and the provider services. There has been a lady in one of, and I'm really gonna try to not identify her, but so I'm not even gonna say which area of town, because everybody will know who I'm talking about, who has been living on a bench for years and years and years. I was told as long as since 2011, and nobody could really get the last name of her. Good citizens have provided her with food and helped her and sometimes the Good Samaritan helps somebody survive on the street, but also perpetuates it when somebody has a mental health issue and cannot see that that's not the place to be and live on a bench on the streets. And so it's been just this week that finally somebody had a breakthrough, an outreach worker with her, and actually together collaborating with police officers, were able to find out what her last name is. And there is a family reunification with another city. The family thought she had been dead for 20 years. They are through the moon. There's now some supports. There's now some family that can help with some legal supports and making things happen. These are really the very, very tough situations to overcome. And so we cannot underestimate how much the street outreach effort and the collaboration around that and the medical, I mean, street psychiatry and the medical needs on the streets and bringing it to the people can do for a very small population that is extremely vulnerable. And those are the people that are going to die on the streets if we don't invest in that type of outreach.
Thank you for that, Judith. And I do believe that that program you mentioned or highlighted it in your presentation, and there was an associated figure with that program. Is that figure kind of in the same vein that Emily was asking a question? Is that figure based on servicing the entire Davidson County area, and for what period of time?
Is that the rapid rehousing that I cited? Is that what you're referring to?
I believe that was the slide, and it had the street outreach as a figure there. I was just
Yes.
curious, is that a good example for this committee and just the city as a whole to take and absorb as a rough order of magnitude around cost and just some context to that figure?
No, that's for 400 people being served. And when you look at a point in time count, that's 2,000 that leaves out, or 7,000 just at the mission. So no, it's not, it's a small percentage. The 800,000 in outreach is going to be mostly focused on the downtown area because frankly, when we look at concentration and people coming in and out throughout the day, that's still the downtown area because we do have the shelters located there. We have the main library there. And there are some of the largest encampments are really just outside of downtown. And so that's a good number for a downtown solid outreach program.
Yeah, thanks for that additional detail. I am being mindful of time, and I do not see any other hands up, but I did want to ask one really quick question. Hopefully, it's a succinct answer that can be given to it. But Beth, you've amassed an amazing amount of information and research over the years, and I'm curious. One of the things that we've talked about a lot in the preservation section of housing and talked about in the group is in really looking at, is there a sunset to some of these dollars that will perpetuate, housing to stay affordable? Or is this truly something you have to commit dollars to every year, annual basis? And I'm just curious if you've seen programs that have had large initial dollars from the onset to really establish programs, right? To establish a certain type of housing. And then there may be some reduction over time, but the effectiveness isn't eroded away. Hopefully that question makes sense.
So I think the answer is different for folks with serious mental illness and for families. And the group we know least about is the people who don't fall into either of those categories, but they're the majority of the folks that are out there. We just haven't studied them. So for folks with serious mental illnesses, we're going to need some ongoing supports. Things like schizophrenia are episodic, so people will need more support and less support at different points in their time. Over the years, when people get to their 50s and 60s, they sort of burn out of schizophrenia so that the symptoms get less severe, and you can probably do with a little less. On the other hand, older adults are going to need other kinds of services. For families, you know, I showed you that homelessness really drops when kids get to public school age. And it's mostly young families who become homeless, and it's probably a temporary need during that period when childcare expenses are high and parents are out of the workforce, and there tend to be young parents who aren't making a lot of money anyway. But over time, they can build up their incomes so that, you know, the housing choice voucher they might have gotten at the beginning costs less to the city, and then is worthless because their incomes are high and they sort of graduate off of the program. Most people who get Section 8 don't stay on it forever. And I think that will be true of families as well. So I think and I don't think we have a good answer for the single individuals who are in neither category. Probably a lot of them will be able, even with just rapid rehousing help that lasts a year, they'll be able to get jobs and income, but not all of them.
No, I appreciate that, and I appreciate the entire committee and those on staff for allowing me to run right up until time with my last few questions I wanted to squeeze in there. Again, thank you, Dr. Shin, for your presentation. Judith, the same, but also for the work that you are doing on a daily basis. Don't want to let you guys leave the call without my thanks, and I believe I would speak for the entire task force in that respect. As we wrap up, I do want to make sure that everyone is aware that we do have our next meeting on Monday. So on Monday at noon, we will, excuse me, we will host Lucy Kemp, our Executive Director of the Planning Department. I will be working as facilitator and likely participant as part of that discussion as well. We do have an additional invite out to another task force member to support and supplement that discussion, but wanted to make sure that everyone leaves tonight knowing that that is on the agenda. So if you have not seen a calendar invite for that, please contact me or Dia. We'll make sure you get that information, but wanted to verbally share it with all of you. And with that, I believe we're good to close. A good round of thanks again for the time spent this evening. And all of those, I'm sure this will be a question via email if I don't ask it, but those presentations will be shared and put on a SharePoint file for all of our community members to access. So also let everyone know that as well.
Yeah. And thanks so much for letting us present this.
No, absolutely. The most appropriate forum. Well, take care, everyone. Have a good evening.
Good night, all.
Thank you.